Hello, everyone. We're just waiting for a couple more people to join, and then we'll get going.
Yeah, before they're
While we're waiting to start, if I can just remind people to please mute their microphones so we don't have background noise. Thank you. So I'm going to start things off. Welcome to everybody that's attended. I'm sure a few more people will come along as well. It's lovely to see you all. My name is Polly Edmonds and I'm the chair of the Palliative Medicine Specialty Advisory Committee. So we're the national committee that oversee training. And I've got a number of colleagues here with me today who are going to talk to you about training in palliative medicine. Just the housekeeping before we properly get going. So as I said, please keep your cameras off during the presentations. Those cameras that are on are all people that are presenting today. Please mute your microphones. We have left plenty of time for questions, so please put your questions in the chat. There's no right or wrong question. There's no silly question. So anything that's on your mind, just put it in the chat. My colleague Fiona Wiseman is going to be just kind of keeping an eye on the chat, and she'll kind of collate themes that we can then come back to. So plonk anything you want to ask in the chat. When we get to the question session, obviously you can also put your hands up. But without further ado, I'm going to hand over to my colleague Cathy Gleeson, who is one of our Kent, Surrey, Sussex TPDs and a member of the SAC, who is going to give you a bit of a context to the discussion today. Thanks, Cathy.
Hello and welcome, everybody. It's lovely to know that you're all out there, and we're hoping to entice you to commit to palliative medicine as a career. The first thing we thought we would do, just to recap, is what's the dual training curriculum about and what might training programs look like. And then what we're going to hear from is three of our junior doctor colleagues who've started on the new curriculum and will give you their thoughts after having done their first year or so. And then I'm really pleased that we've got some colleagues who are consultants in palliative medicine working in a range of roles. So we thought it would be helpful for you to hear what sort of jobs might be your future careers. And of course, they will change and evolve over time. And then, as Polly says, we've got plenty of time for questions, so do keep them coming and pop them in the chat. So perhaps we could move on to the next slide now, please. So we wanted to talk about why you might consider choosing palliative medicine. We're all biased. We think it's a great career and that's why we're doing it. But in terms of what we think of it and what we hope you would, it's a specialty that, like some others, has a very holistic approach, working within a team. The doctors in the team are an essential component, but they are by no means the most important. We all work together, and in supporting our patients, you need a very rounded approach because it will encompass all the difficulties that people might have when facing a serious or life-limiting illness. And so we practice wherever those patients need to be. Small numbers of them would be in a hospice inpatient unit for periods of time, but the vast majority of the people we support are at home, either in their own home, nursing homes, or perhaps in hospitals as well. So it's very important to have a collaborative approach, and I would say our specialty prioritises that highly, and we're quite good at navigating and negotiating. The consultant careers that we have are all very flexible, and there's no doubt that they're evolving and changing. There are very important aspects of service development to meet patients' needs as those change. And we're usually very actively involved in education, enhancing the skills of our peers, educating the trainees that come through, and influencing research and policy. Next slide, please. So in terms of what the curriculum means and how it's constructed, in order to meet patients' needs, we have now moved to an approach that interweaves internal medicine and palliative medicine experience and skills. And that's really because our patient cohort are changing. Palliative medicine was set up initially to look after primarily those with cancer, but we've all long ago realised that people with other illnesses and conditions struggle just as much. And so we're looking after many more people. Over 50% of our patients have long-term conditions that are not cancer, and that number is rising all the time. People are therefore living with complex needs, complex symptoms, enormous impact on their personal and social situations, and they are receiving treatments that in themselves have consequences, and they sometimes have to live with those. So we need broad general medical skills to meet those needs, and the internal medicine aspects will skill you up to bring both acute and detailed assessments of general medical conditions wherever those patients are, be that rapid response in the community, front door of the hospital. You know, there's a whole range of places where people will need our help. Could we have the next slide, please? So in terms of how we're going to do that, most of the programs have blocks of internal medicine so that you can concentrate for periods of time gaining those or maintaining and gaining those internal medicine skills. But we recognise that there need to be blocks of time in the different dimensions of palliative medicine training. So that's blocks of time in a hospice, community service, working in a hospital palliative care team. And you may want to build on specific areas of skill like oncology unit or units with special interests. So we try to ensure that it's a tailored programme while maintaining your skills across the programme, which is 4 years. So there will be essential days where you keep your skills in internal medicine while doing palliative medicine and vice versa. So you can see I've put there quite a few different opportunities that there will be for training, both in the assessment skills of acutely sick patients, but also the continuing care of people in outpatients and community, and the procedures that are relevant to both palliative medicine and internal medicine. Could we have the next slide, please? So examples of what that might look like. If you think about a 4-year programme, then there will be blocks where you are in palliative medicine or internal medicine. And they're structured slightly differently across our regions. So depending on where you're interested in training, it would be worth finding out what sort of options there are for the blocks of training in your region of interest. You may, of course, be looking at several regions, so have a look at comparing those. The one on the top here is the one I'm familiar with in London and KSS, but there are many other places that are doing a 6-month block of internal medicine at a time. The one consistency is you need to maintain IM skills throughout your training, and you need to do a block of it in the final year of training to ensure that you can gain your CCT both in internal medicine and palliative medicine and feel fully equipped by the time you reach the end of your training. So if we could have the next slide, please. As with every other specialty, we're keen to ensure you have a rounded experience as you train to become a consultant. And so there will be opportunities to do a whole range of other training type experiences. Out of programme experiences are fully supported by our specialty, and lots of people take the opportunity to have a year out doing perhaps an education fellowship, a specific training experience in a related specialty, or perhaps building on research interests and spending time doing a more extended period of research. We have the option for academic training and leadership training with fellowships and chief registrar roles. And then for others, they combine palliative medicine with special areas of interest, perhaps education, informatics, public health. There's all sorts of options available. So I suppose what we want you to understand is that we're an enthusiastic bunch of trainers who really want you to combine the skills you need to be a consultant, but have an enjoyable educational experience along the way. So having said that, I thought the next people to hear from would be some of our young colleagues who have embarked on the new curriculum. And so I'd like to welcome Molly, Hannah and Emma, who are going to spend some time talking to you about how it's been for them so far. Thank you.
So hi everyone, I'm Molly. I'm an ST5 in London at the moment. I just thought I would sort of show my journey so far. So I started in October 2022 on the new curriculum after completing IMT in Northwest London. So I started on my acute block at Barnet Hospital. So I was working in the acute medicine unit as the sort of acute reg, and also completing kind of med reg on calls and take shifts as well. And during that period, I had a block of 4 days where I spent time with the Barnet palliative care team to kind of start my journey of learning to be a palliative care reg. This was then followed by an 8-month block with the inpatient palliative care team at UCLH, which is a sort of an advisory service, and got to see a huge variety of patients and work with a really fantastic team there. And during again that period, I went back to Barnet to complete maintaining capability days, and I chose to do them in the ambulatory care unit because my internal medicine supervisor, that was where he worked. So for sort of continuity and completing assessments and things, it made sense to go back there. So I've just started ST5. I've started at the Marie Curie Hospice in Hampstead. I have my block of 4 months of sort of general medicine again, but this time at Jerry's, and going back to Barnet. So getting that kind of continuity with the acute team and the general medicine team. And then I'll return to complete the year at the inpatient palliative care team with the Royal Free. Next slide, please. So I guess a little bit about why I chose palliative medicine. It was always something that I was really interested in, but actually initially thought I would be an obs and gynae trainee. But during my sort of time as a working doctor, I realised that I wasn't a surgeon, and actually really just enjoying time with the patient and their narrative was the most important thing to me. And I think so far, although I'm in the very early stages of my training, I've really enjoyed working as a team, and I hadn't really appreciated what that felt until now. And particularly when I was at UCH, I felt completely kind of immersed in their team and had kind of really great relationships with the nurses and the consultants, and they had a clinical psychologist, and got to have this sort of wonderful experience where every day I went to work and felt like a sort of a bit of a unit that all looked after each other and worked together. So the opportunities of dual training, I think, are vast, and I think it really does enrich us as trainees. I certainly feel that we see patients with all different presentations, different diseases, and it's sort of helpful to have that good grounding in understanding kind of what they're facing and the medications that maybe they're on and their journey. And I think it's really useful also to meet the other registrars in other specialties in other settings. So particularly when I was at Barnet, I had sort of good working relationships with the rest regs and the cardio regs, and then would also meet them again as a palliative care reg. And I think that was really helpful to sort of form relationships and also hopefully get them on side that we're a really useful specialty and very much needed to work with them. There are, of course, some challenges of dual training, and I think it is certainly, to be noted that it is hard to keep up with two curriculums, and making sure that you're kind of remaining competent both as a general medic, but also as a palliative care reg. And sometimes it can be difficult to switch your mindset between the two, because certainly kind of how I am as a palliative care reg is not necessarily how I am as a med reg, but my internal medicine supervisor, who is a geriatrician, constantly reminds me that everybody else also has this this sort of debate and kind of balance, and that you can be both and be both successfully. And I guess why it is the best specialty. So I genuinely think I have such a privilege doing my job. I get to meet patients and their families and spend sort of time with them and get to hear things that I wouldn't otherwise have and make a real difference. And I think that really the people I work with are incredibly inspiring. I'm always inspired by the nurses, by the consultants, and it makes me want to do better and be better for my patients. So yeah, thank you. Next slide.
Good afternoon. My name's Hannah. I'm also an ST5 in London, and I am a graduate medic. So my background was in religious studies and anthropology. And similar to Molly, I did foundation and then an F3, and then I did IMT 1, 2, and 3 in London as well before moving straight on to ST4. And my goal from fairly early on in my medical training was to not be a medical registrar. So it is slightly ironic that I'm here doing this talk today. So just a couple of reflections for anybody who's slightly daunted by the role of medical registrar. I guess I'd firstly just say that it's a gradual accumulation of skills. You're not expected to be able to function as a medical registrar as an F1, so it's kind of not. Don't even think about it until you have to, I guess would be my advice to myself. You learn a lot just by being surrounded. So I can remember eavesdropping or sitting near the medical registrar when they were taking referrals, listening to the kind of questions they asked, listening to their kind of approach, and you actually pick up so much doing that. And everybody just working as any sort of doctor will be gaining skills in clinical leadership and prioritization and diplomacy, all of which are really useful. Medical registrar definitely has its perks as well. I personally am really motivated by trying to avoid admissions for people who don't really need to be in hospital. I think we've all been on ward rounds when you're trying to help a patient and thinking, why on earth are they in hospital? Who admitted them? So to be able to be that person to find other solutions is exciting. And I think you are a leader and you do get to have influence in things like tone and culture. So just small things like checking in with the rest of your take team and making sure people have had lunch breaks and seeing if the ward cover team are doing okay. Those things are really powerful. And I would also just highlight that being a medical registrar, I tell myself this, is temporary as well. What I'm really excited about is the bit that comes after. I won't be doing medical registrar shifts forever, but I do get the chance to do palliative care for the rest of my career, so I'm excited by that. My palliative training program has been slightly similar and different to Molly's. So I was in a DGH for the whole of my ST4. And I've been in hospice for ST5, and I've done a sandwich structure in both of those years where I do palliative care and then a gen med block and then back to palliative care. I did acute med in ST4 and I'm doing geriatrics in ST5. And in those discrete blocks, I only do palliative care on calls during my palliative block and only do med reg on calls during my general medicine block. And I've done no night shifts at all as a palliative medicine trainee, which does have implications both on money, but really on work-life balance as well. It's been just life is really different when you're in those two blocks. Some of my thoughts on dual training so far. I've been excited to be able to maintain the investment of 6 years of hard work, kind of understanding what a hyponatremia screen is and how to treat infective exacerbations of COPD. So to be able to carry on using that, I found fulfilling. And to a large extent, hospital medicine is my comfort zone. I feel much more at ease there than I do in the hospice right now. So I've liked the kind of the easing in. I don't know whether I should say this or not, but I do find internal medicine kind of a little bit of an emotional break, just to have kind of, just to be immersed in kind of curative medicine every now and then. It's really exciting. So I do like general medicine, and I am pleased to be able to continue doing it. And I mean, much has been said already about how the dual training program does just make you a more well-rounded doctor. I think there are challenges. So I have lots of transitions in my program and all transitions are stressful. I think having that continuity of DGH has been really good. And you do just have to be intentional about maintaining your confidence and competence in general medicine, and spacing it out has been valuable for me. And then finally, some of the best things about being a palliative care trainee. I think the thing that really strikes me is that I've genuinely felt invested in as a trainee. I've felt like I've been mentored by my educational supervisors for palliative medicine both years. I mean, they've both put in kind of fortnightly calendar appointments with me to talk about my training and to be doing teaching and assessments, which is really different to my experiences of educational supervision so far. Similarly, like Molly, we get some kind of psychological support in hospice, and we are a small specialty, which means there's quite a community feel. So I'm pretty sure my TPDs know my name in palliative medicine, which has not been my experience in general medicine so far. So I'm really happy to be doing dual training and would thoroughly recommend it. And that's over to Emma. Next slide, thanks.
Thank you. Hi everyone, my name's Emma Sugru. I'm a ST5 in Liverpool. So my kind of entry into palliative care has been a little bit different to what we've heard so far. So I did foundation and core medical training as it was before IMT became a thing. And I was working as a specialty doctor in palliative medicine within a acute hospital inpatient unit for 2 years prior to going into training. So during those 2 years, the training pathway and curriculum changed, and I kind of had to line up my experience to those who were doing IMT. So I did a little bit of general medicine and medical reg on calls during my specialty doctor years, which then meant that I was kind of equivalent to IMT to be able to apply. So I entered ST4 in October last year, and my first job was hospice inpatient unit based, just to kind of really solidify that experience and something a bit different to the hospital unit I had worked in before. During that time, so the first 12 months, we do kind of maintaining capability within internal medicine because I didn't have a block within my ST4 year. So that's been structured for me as like hot blocks. So every for the year, you're supposed to do equivalent of 12 shifts, so 1 shift a month, but it felt a bit more meaningful to kind of do it as a week at a time. So I've done 3 separate weeks of acute medicine through my ST4 year. The other thing that is kind of new and unique is that you have the opportunity to do a clinic, an outpatient clinic that's not palliative medicine based. So I do a movement disorders clinic, mostly with Parkinson's disease patients. And that's usually every couple of months, every 6 to 8 weeks or so that I've been doing that. I think you're supposed to do 20 of those clinics across your training. So it's been really interesting to kind of integrate into those other areas and really see the value of collaborative working with other specialties. I think from my perspective, going into acute medicine and from theirs, having somebody who's kind of interested in palliative care going into acute medicine has been very mutually beneficial for us and for the patients. I think it is unique. We have a couple of things unique to us that are different. So the on-call structures are slightly different. For your palliative medicine rotations, usually you do remote on-calls, which is new, and you're usually able to be at home and providing phone advice or coming in for a specific kind of inpatient unit. It does take a bit of getting used to, but it's not the same and as kind of being present in the hospital, and it's not got the same kind of tiring feel to it. I think as well, the others have alluded to the kind of strong MDT working that we have within palliative medicine. We are rarely kind of isolated in terms of patient care and decision making, and I think that that's a real benefit. We learn so much from our colleagues, and that kind of networking with other specialties, I think, is really the kind of new curriculum has really kind of brought that to the fore as well. I haven't done my kind of acute medicine blocks yet. They come at the end of my ST5, and then I've got 3 4-month blocks for the rest of my training, so 1 each year. But just on my reflections as a medical registrar, I think it does have a bit of a reputation, and often people don't feel that kind of keen to pursue that. But once you're in it, I do feel it is empowering. I think you can make a difference, and you can bring the kind of unique elements of your specialty and your skills and knowledge to that setting as well. So yeah, I would encourage anybody who's keen to kind of start doing what you can to get specialty specific things under your belt for your CV and application, and to go for it. It's definitely worth it. Thank you.
So I think now we'll hear from consultant colleagues. So I'm pleased to introduce Matt as the first one.
Thank you very much, Kathy, and welcome to everybody here. My name's Dr. Matthew Carey. I am a consultant in Oxford in palliative medicine and training programme director for the Thames Valley Palliative Medicine Training Programme. And this is just a quick slide to show you an example of what my consultant role looks like as a consultant in my job. We have a rotational approach to how we deliver palliative medicine. So there are 8 colleagues of mine, and we across the board cover hospice inpatients at 2 inpatient sites, hospital liaison at 3 hospitals, and then a large community for the entirety of Oxfordshire and some of Northamptonshire, including our hospice at home. And we often sit in one of those main clinical areas for a couple of years to enjoy it and develop it before rotating out to keep ourselves fresh in the different branches of what palliative medicine has to offer. Myself, at the moment, I'm currently on the Sobel inpatient unit, so I look after 18 patients there with a team of junior doctors, registrars and GP trainees and specialty doctors, all of whom are really excellent. But alongside the 3 main branches of palliative medicine, there are also other elements to our job that you will get to do as a consultant. One of the main ones is supportive care. Supportive care is another arm of palliative medicine where palliative care skills are brought to the MDT of other specialties. So, for example, I input into patients on the early phase clinical trials units a bit earlier than perhaps we would if they were under our community palliative care team, and help support those patients in that group. And renal supportive care, so I provide support and input into patients who elect to go through a non-dialytic pathway for their management of end-stage kidney disease. And going back to what Kathy was saying about having fellowships, we're very fortunate. We currently have a fellowship at the moment of a trainee who's joined us to develop palliative renal supportive care skills, which is really good. Alongside that clinical focus, though, there are other elements that we all complete. So education work, training program director, and teaching of medical students is a big part of my job. And just to say that when you become a consultant, it never ends. You almost feel like you've kind of made it, but actually it's the end of the beginning as opposed to the beginning of the end, which is what I thought it would be. So, for example, I've managed to complete a PG cert in teaching and learning since I've been a consultant, very kindly sponsored by the University of Oxford because of teaching medical students. So there's lots of things you can continue to do even once you've made it as a consultant. And then the other element of what we do is quality improvement and research. There's several different things that we're doing at the moment. For example, in our hospice, we have a variety of trainees who are looking at QIP, looking at cognitive dysfunction on the inpatient unit. So I'm helping them lead that. I'm very fortunate as well to have a non-working day that's been developed across the board for all of us as consultants who recognise the impact that I think the trainees were highlighting earlier that it can have on you. So we all have a 4-day week, which I'm very grateful for. And one of that flexibility in palliative medicine is one of the key things that attracted me to it. Thank you. Next slide, please.
Hello, I'm Andrew Kodabakis. I'm a consultant in palliative medicine in West Lancashire, Southport and Formby. So I'm going to share with you my current job plan, which really is a mixture of hospital and community working. I've had the privilege over the course of my career to have been both an academic clinical fellow in palliative medicine, to have had one of the leadership roles before entering palliative medicine training, and I've also worked in tertiary services and different hospices as well. And what I would say is that my training that I've had has really enabled me in my post-registrar career, into my consultant career, to really be able to take this forward and to work in different care settings, and that is a really important part of what we train our doctors to do, to be able to provide care in hospital, community and inpatient units, be that in a hospice or a hospital. So one of the things that I'm working on the moment is our virtual ward. There's a big push within health services to try and deliver more complex care at home. And I've taken that on with some fantastic colleagues here to try and provide that. So we have a virtual ward board round every morning. And I then go and provide some urgent response to both hospital and community patients as required. I also have an outpatient clinic, and that's really good for that longitudinal care, to try and provide support to people who, again, may not be typically supported by our palliative care nursing colleagues, but actually we're able to provide some input from there. I'm also training program director for the Mersey rotation, and that's kind of integrated throughout. Team education is very important, so that's something that we do on our Wednesdays alongside other MDTs that we hold, and that's both in cancer and non-cancer services. So I've got a particular interest in advanced liver disease and in some elements related to gastroenterology and nutrition as well, and that's something that I've been part of. Again, I'd kind of echo what Matt has said, that it's having that diversity that makes palliative medicine so much different compared to other specialties. And I'd like to introduce Dr. Liz Fleming, who's taken on the new internal medicine work with palliative medicine, and she's going to talk to us about her role now.
Thank you very much. So hi, I'm Liz Fleming and I'm a new consultant this year. So I completed my higher specialty training this year in palliative medicine and internal medicine. And the drive for me to dual qualify was to fulfill my wish of being a joint consultant in both acute and palliative medicine. Now, I fully appreciate that it's not everyone's passion to work as a consultant in acute medicine, and I do want to be clear that the dual curriculum does not mean that you're obliged to work in acute medicine as a consultant, but more that this is an example of what opportunities could be available from dual training. So this is an example of my working week. So my time is split 50-50 between palliative medicine and acute medicine. So when I'm working in palliative medicine, I'm working in the hospital liaison team. I work with the MDT, we do teaching medical students, and there's a lot of diversity in that role as well. And then when I'm working in acute medicine, I'm working as an acute medical consultant in ambulatory care and also the acute medicine, the acute admissions unit. Now, due to the nature of acute medicine rota, it's a lot of shift work, so no working week is the same to me, and it'll also be very dependent on how acute medicine is run in the trust that you're based in. So I think dual training can offer you lots of opportunities in your future career, and I think it's worth just reflecting on any sort of special interests that you might have at the moment, and think about that how dual training could offer you to keep working in those as a consultant. Thank you.
So if we could have the next slide, please. I just hope that that's given you a flavour of what our current junior doctors are feeling and thinking as they embark on their career in our specialty, and also perhaps a range of possibilities for how the future jobs might pan out. And there will be a huge number of other varieties. I mentioned at the beginning that the structure of programmes varies across regions. Each region has its own training programme director, and so we've put into this slide the contact details for those TPDs, so that if you want to find out a bit more information, you'd be very welcome to contact us. Contact a range of regions if that's what you're considering, but I know many people have ties to particular regions. So I'd like to thank you all for listening to us, and we'd really love to listen to you now. So I'm going to hand back to Polly and Fiona, who will coordinate any questions you might have.
Thank you so much, Kathy. I'd written down a suggestion for everybody to talk to their local educational supervisors or training leads in palliative medicine and their TPD. So I would just really encourage you to do that. So talk to people locally who are doing palliative care so you can get a better sense, and hopefully as part of your IM SIP in palliative care as well, you'll have a chance to, if you're interested, spend some time with your local teams, do a quip with them, because I think it's very easy for us to talk to you, but it's much more helpful to really get a sense on the ground about what it's really like to inform your applications. So thank you very much for listening. I can see that some questions are beginning to come into the chat. Fiona, do you want to kick off?
Sure. So thank you for your questions, and do keep them coming. One of the early questions was this presentation going to be recorded? And yes, it is. And I think Vicky will probably give us details about how you can access that afterwards. Josh has asked a question: could anyone share their experience of developing a subspecialty interest in before and during their training, and how they went about pursuing it? Are there common subspecialty options out there? I don't know who would like to answer that question. Kathy, would that be something you want to take?
Well, I can start it out. So my particular interest has actually always been in education. So I, as a registrar, made it my business to get involved in teaching frequently, and did that for local GPs, for local junior doctors. And then as I went into my consultant role, a little bit like Matt was saying, I reached a point where I felt I wanted to know more and feel that I had a little more knowledge myself. So I went on to do a master's in clinical education, and I really loved doing that. I'd been a consultant about 8 years. It took me about 3 years, less than full time, but I felt it gave me the grounding and, if I'm honest, credibility to have a view. And here I am. It's stood me in good stead. So education has been what I've really loved. But I know that we have, for example, within our rotation, one trainee who has always kept their interest in education from when they were a clinical fellow prior to specialty training. They work at a medical school and have been very involved developing modules for the medical school. And so that trainee has trained less than full time in order to continue 1 day a week with the medical school. So that's an example. We have trainees in London and KSS who've developed experience and expertise in SIM, having started out as SIM fellows, and have developed simulation program for trainees on the previous curriculum. And I know that there are trainees now looking at opportunities for developing SIM with other Group 1 specialties to ensure that the internal medicine SIM is available for our trainees. We've had others interested in ethics who did ethics masters during their training and have gone on to have roles in medical ethics, either in their clinical role and being part of the ethics committees in their particular place of work, or working at a higher profile, for example, with the Association of Palliative Medicine. So those are just some. We've also had chief registrars who, perhaps one story was a trainee of mine who was frustrated by some of the things he felt didn't work very well, and did them as local quips with us, and then went on to be a chief registrar, and is now busy sorting out his consultant role in the unit he works in using his management skills. So there's a whole range of opportunities. Others may have other ideas.
Does anybody else want to add to Kathy's answer? I think that was quite a thorough response, covering different subspecialties.
Just to add, Fiona, that I think has been said in the chat, there is no official subspecialty when you undertake palliative medicine training. I think that's important, but you can develop your own flavour, your own choice. One of the things about palliative medicine that is great is the 3 sort of branches of community, hospice, inpatient and hospital are all at your fingertips, and people do often find an area that they like to settle in. But equally, I'm very fortunate we still do all of them, even if we still have preferences. There are some emerging areas of specialist interest. So, for example, as I said, I do renal palliative medicine, which if you'd have asked me, I ended up landing in it, but actually love it now. It's really, really good and engaging. So my advice is if people do want to, explore an interest, is just show an interest, go and meet people, sit in on clinics and see where it goes. There's usually someone in palliative medicine that shares that interest and has kind of made traction down that path anyway. So you'll be able to kind of find similar people. And I think all of us here will say we're a very friendly and super supportive bunch. So if you have an interest, we would support you going off and developing it and exploring it further.
No, that's great. Thank you, Matt. And that probably fits into one of the other questions in there. Is there any scope for joining a joint interest in neurology, seeing patients with advanced MND, Parkinson's and MS, etc.? And I think the answer to that is absolutely. I mean, I think that would probably form very much part of the palliative curriculum anyway. And then many of us may have a bit more of an interest in that. Kathy?
I just wanted to add in that you'll find that many units work alongside other specialties to develop joint clinics. So there may well be joint neurology clinics. We have a palliative medicine consultant there working alongside a neurologist, same in a heart failure clinic, same in respiratory disease, because we recognise very clearly that there are, people have a range of problems, and sometimes, for many conditions you have to live with it, and so you have to learn to live with managing your symptoms, and we can bring expertise in that. Andrew?
Yeah, so I did a home visit yesterday to someone who's got sequelae from an advanced neurological condition that probably has a longer prognosis. It's not just about those of the last weeks or months of their life, and really trying to help support with some of the consequences of his condition. And obviously Emma kind of shared with us a bit about the work that she's doing in an outpatient basis, albeit with an IM focus, but there's natural kind of sisterhood, isn't there, with neurology and movement disorders. And I don't know if you wanted to share a bit more about how your experience has been in terms of integrating the palliative medicine and the internal medicine in that.
Emma, you're just on mute at the moment.
Sorry.
That's it.
Yeah, it's been really interesting. I think obviously it's mainly Parkinson's disease, but there are kind of Parkinson's plus diagnoses as well. I think if there's a particular patient that would benefit from palliative care kind of focus, we kind of cherry pick those from the list of patients that are coming to the clinic, and I would see those. But I still have a variety, so I'm involved in the kind of newly diagnosed people as well. But yeah, it has been really interesting, and I think just developing that knowledge and skill of how you would manage those patients longer term and into their kind of end of life care and last days of life. What do you do with Parkinson's meds and things like that? It has been really useful, and I guess just having that kind of special interest in movement disorders is fairly unique, I guess, within our region as well. So hopefully something that I'll carry on with, as I get more senior.
Thank you, Emma.
Thank you.
One of the questions, and I think we often get asked this, is people are keen to go into palliative medicine, but they might not actually have a palliative medicine block as part of their foundation or IM training. How might they go about getting the relevant experience? And are there any top tips of the things that they should be doing? I don't know whether would Molly or Hannah be happy to take this?
Hannah, you butt in if you want to say anything, but I think you don't need to have necessarily specific palliative medicine experience. You will be, I'm sure, looking after sort of quite complex, maybe palliative patients on the wards and your Jerry's job or on the acute. And I think thinking about that and doing reflections that can support your application is really important. Also linking in with your hospital palliative care team. I'm sure they'd be very happy for you to come and sit in the MDTs or do a ward round with one of the consultants. So definitely you can be quite creative with how you are going to sort of show your interest and your passion, and it doesn't have to be in that very specific I've done a block of palliative medicine and this is what I did. Hannah, is there anything you want to add?
I had never worked in palliative care at all when I applied to ST4, and the way that I got experience was similar to like you were saying, Molly. I got lots of palliative experience just by doing general medicine, and I also did do a quip about advanced care planning whilst in hospital, and I did a few taster days as well, so that was possible whilst doing IMT. Yeah, just get creative.
Thank you. Does anybody want to add anything to that? No, I think that hopefully answers. Oh, Kathy?
I was only going to say, you know, I think quips are a good way to do that, because actually what we're looking for is an interest in the specialty. So we recognise that not everyone can do a job. But if you've looked at the palliative aspects of how you work and how to improve aspects of that or learn more about it, then that's great. That shows keenness, and that's what we're looking for.
Thank you. We've got a question here about CSER and how CSER might be possible with the new curriculum. Polly, do you want to take that? It's something we've certainly discussed.
It is. So after October 2024, so from November 2024, all new CSER applications will need to be on the new, that's the 2022 curriculum, which is a dual training curriculum. So you would need to demonstrate that you have the knowledge, skills and attributes to be on the specialist register for IM and for palliative medicine. So it would be a dual CSER from November next year onwards.
Thank you. Does anyone have any experience of dual training in other specialties, for example, intensive care medicine? If that's with palliative medicine, there's no other recognised dual way of training at this moment in time. I think sometimes people have created a slightly bespoke way of going through it, but there's no formalised sort of approved curriculum for that at present. Another question. Oh, sorry, Matt.
Sorry, thanks, Fiona. Just to say, going back to the kind of supportive thing, we're actually on next summer, a trainee in intensive care medicine wants to develop some palliative medicine skills. So they are going to join us on a fellowship for the year, which they've discussed with the intensive care medicine faculty and developed a curriculum for, and all sorts of exciting things. So it's just to highlight that there are always ways and opportunities to do these things. We're flexible, intensive care seem to be quite flexible. So if you are interested, don't lose hope. See what you can do.
Thank you, Matt. As a consultant who is dual trained, would you be expected to do GIM on call? Liz, I just wonder if we can make use of your experience there, please.
Yeah, and no, I think there is no sort of real expectation at the moment. I think it's very much, I guess we're quite lucky in that it's all quite new, and really it's just about having conversations with the trusts where you might be thinking of working as a consultant about what opportunities there are and what they can offer. So for me personally, I was asked if I wanted to do palliative medicine on calls or general medicine on calls. I chose to do general medicine on calls, but that was very much my choice, and it's certainly not, it wasn't an obligation or an expectation. So I think it's all, as everyone else is saying, if you've got special interests, if the things that you're passionate, just talk to people in your area, because that's where you get most opportunity from.
Thank you. Kathy?
I think the important thing to remember is that the reason for the dual curriculum is to broaden our skills to encompass more experience in general medicine, and that's an acknowledgement of the changing cohort of palliative medicine patients, or patients referred to a palliative medicine service or palliative care service. And when we look ahead to where the consultant posts will be, there's a huge need for palliative care consultants across all the settings that patients need you. So that's hospice inpatient units, community teams, hospital palliative care teams. And, you know, the IM skills that you will be gaining will be really important to support those patients effectively and well. So it's not an inevitability that you'll end up doing acute medicine. I think you need to see this curriculum as preparing you to cope with what crops up in palliative medicine.
Thank you. One question I think might just be worth going over is about the entry into palliative medicine. There's a question here about entering palliative medicine from ACCS instead of IMT. Polly, do you want to just take that?
Yeah, so I mean, with our previous curriculum, there were multiple points of entry, but because this is now a dual training curriculum with IMT, even people who've come from a non-standard route will need to meet the requirements of the IMT 3 or stage 1 curriculum in order to be eligible to apply for palliative medicine at ST4, the same for any group 1 specialty. So if you have started in ACCS, you would then need to be sitting down with an IM supervisor to look at your capabilities, how they map across the IM curriculum, and you would almost certainly need to be doing an IM 3 year in order to be able to then complete effectively, be signed off for IM stage 1 to then be eligible. So it's not a no. There is, there is obviously cross fertilization between different entry points, but you would still need to be able to ultimately be signed off on IM stage 1. That wouldn't necessarily involve doing the whole of IMT stage 1 if you've started in ACCS, but obviously you would need to look with somebody at what you've done, what your capabilities were, map that across, look at the gap, and then think about how you meet that.
Thank you. A good question here about are there any training pathways for IMGs through MTI pathway in palliative care? Does anybody have any experience of that on the panel?
I think Andrew and I was going to say Andrew and I put some stuff in the chat about it, but you carry on, Matt.
Lovely, thank you.
I was just going to say we have a gentleman who's an IMG who came and completed his IMT3 equivalence in the UK over a number of years and developed the competence, and he applied very successfully and is successfully completing our training program at the moment. So my advice would be very much to talk to your local team about it. Just get some help with what you need to do next and how you move forward.
Thank you, and thank you, Polly and Andrew, for putting some information in the chat. I think this is one of the things that when Molly, Hannah and Emma were talking, that question of people being quite nervous when they haven't done general medicine for quite a while and how they've managed that transition. I think you very kindly shared some of your experiences and top tips. Is there anything else you'd like to add at all? And I'm looking at Molly and Hannah. I think Hannah, you were very honest.
I mean, to be honest, I was nervous between transitioning from just normal ward work to an on-call block when I was doing IMT as well. So I think the anxiety around med-regging isn't unique to palliative care. And I think my advice to myself is just to do little and often. So some of that is designed for you in the maintaining competence days. So for every 1 month of palliative care you do 1 day in general medicine, and that's of your choosing. So whatever you think will help you to feel more confident and competent. Really design it to benefit you the most, and really small things for me just help kind of maintaining that perspective. So reading the BMJ when I couldn't bring myself to do it just helped me to feel like I'm still a part of that world as well. Molly, what do you think?
I always like loads of candles before a night shift, so bubble bath and candles, but no, it's fine. I think just everybody gets nervous, and I don't know, I think kind of just seeking support from friends and colleagues as well, because I think there's probably very few people that really kind of never get nervous before med-regging shifts and things.
Emma?
Yeah, I think I would say you have done it, and sometimes we have to kind of remind ourselves that, like, you've ridden a bike before, and once you get back into it, it kind of comes flooding back. I don't think you lose it that quickly or easily, and so many of the skills that you use as a medical reg or as a palliative medicine trainee or whatever specialty you're working in are transferable. There's obviously specific parts of knowledge that are required, but your kind of team management and all of those things you will be using day to day anyway. So I think it's just like the others have said, it's confidence and knowing like you have done it and you will be able to do it again.
Thank you. A question again around the acute medical role, and I wonder whether Liz could take this, is whether you had to do any additional competences or whether your training made you competent and had the appropriate skills to do the job that you're doing.
So I guess it's just to sort of be clear. So when we do dual training, you dual training in palliative medicine and internal medicine, so that gives you the expertise to be able to do general medicine on calls in the same way that respiratory or cardiology trainees gain the internal medicine to be able to do the skills to do the internal medicine on calls. So it's just that the way the trust that I work in, the GIM, is sort of acute medicine, so that's where it is. So it's the internal medicine skills that I gained through doing the dual training gave me the competencies and confidence to be able to do the role that I'm doing now. I will say that, as everyone else has said, you don't stop learning when you're a consultant, and I'm still learning every single day. I'm still very new in my post, but it's great to have supportive colleagues in palliative medicine. You always have supportive colleagues around you to be able to grow as a person and do so many breadth of different things, as everyone sort of talked about today. So I feel very privileged for that.
Thank you. An important question here about, I found it emotionally draining when approaching people in the last days of life. Will we be able to cope emotionally in the long term, please? So I suppose this is a bit about our self-care and resilience, isn't it? Would any of the panel like to take that and share their experiences of their strategies?
I put a little bit. Oh, so sorry, Kathy, you go ahead. No, I was going to say I put a bit in the chat, but about clinical supervision, which most units will put in place for trainees, and I think is really important. But I guess I think what I would reflect on is that you need to have a really think about your work-life balance, and you need to think about the things that you do outside of work and your support systems outside of work that give you that balance. I think that's really important. You know, if work is your life, it's a pretty tough gig doing palliative medicine then. So you do really need to think about, you know, about how rounded your life is, and so that you've got strategies to de-stress. Now, whether that's through, you know, theatre or music or exercise or whatever it is, for family, friends, it doesn't matter. There's no right or wrong, but it's just making sure that you do develop those strategies so that you can have time out and time away. Kathy, add to that if you want.
Well, I think for me, I would advise as well to have balance and variety in your work, because I think if you're getting up in the morning to do something that you enjoy, that's hugely beneficial. So I completely agree with everything that's been said, but also think about the variety in your work. And so for me, balancing clinical patient work, which I love, with non-clinical things like education, I oversee the medicines management groups and governance aspects. You know, I have a variety in my week, and that keeps me sane as well. I think if I saw patients all day, every day, I might worry. So for me, it's about having a range and also a sense of progression. So have things that you're looking ahead to, and maybe consider either, like Matt's variety of rotational work. For me, it was a progression in taking on additional or different roles, you know, every 5 years or so. My career hasn't stayed the same. So I think it's balance in all aspects of your life.
Thank you. Andrew?
I would say a lot of it is about the transition. So when you're at IMT stage 1, you're often on the wards in the thick of it all the time. You then go to stage 2 and registrar training, and that expands a little bit more, and it's a different skill set that you bring. That yet again, when you become a consultant, you're dipping in and out to other things, and you're kind of managing a population rather than an individual as well with things. So I would say that my learning has been that has changed over time, and what the intensity is different. And what I finally do is that I garden well and I play piano badly, and that sorts me out.
Thank you. And perhaps just the final question, because we're bang on 2 o'clock. With the NHS under pressure and changing, has the private sector impacted on your jobs, and has this presented challenges and/or opportunities? Does anybody have any experience with that?
I think that probably of the panel, relatively limited experience. I think some palliative care services are commissioned to provide cover to private hospitals. So there is in London there is an example of that, where one of the NHS palliative care services, as part of its role, covers a number of private hospitals, and that's fully commissioned. There are also some examples in some of the more affluent parts of the country where palliative medicine consultants have grouped together to provide some private palliative care. But if you're looking at palliative medicine as a career to make money in the private sector, we're not the one for you. It's relatively small, and I think the other thing that I would say is that palliative medicine as a career is all about working as a consultant in a multi-professional team, and as a single palliative medicine consultant, you're not the team. So what you provide one-to-one in terms of private palliative care is not the same as what actually you get through the generic palliative care services. So that's a plug for the generic services rather than for the private. I mean, I think that one of the issues that perhaps you're alluding to, though, is that a lot of palliative care happens outside of the NHS through the charitable sector, and that is an issue because it's very reliant on charitable funding, because often even though they will have NHS contracting, that doesn't pay all the costs, and that is an ongoing issue. But that's a webinar for another day, because we'd be here all night. I'm going to call this to a halt because it's 2 o'clock. Thank you so much, all of you, for coming. We've had a really good audience. Thank you for all your fantastic questions. We will try and pull these together into some FAQs, and with Vicky's help, we'll try and make sure that there's a link to them on the portfolio so you can access that, ditto with the recording of this meeting, so that people that weren't able to join today will be able to listen in. So please do, if you've got friends that are thinking about palliative medicine, just encourage them to have a listen. And please do talk to your local palliative medicine leads just to find out a bit more. Thank you very much indeed. Thank you for your time. Goodbye.